Are we? So that we're gonna just go to the Tableau website for DataPoints, and she's gonna be able to all pop up and set up work. Okay.
So Chris, is my friend working you too hard tomorrow?
She wasn't mine. She said
Yeah.
she's trained. I will.
All right. Good afternoon, everyone. We're going to get started. Thank you, everyone, for being here today. I'm sure, like many of you, I was up late last night watching all of the results coming in. So a lot of interesting news today. But we're here to talk about healthcare. I think I want to start off by going around the room and just quickly introducing ourselves. As always, we do have a live stream going on the internet. People are participating remotely, so do ask that you use the microphones. Green means go microphone. So people start right over here.
Rich Buckley, AstraZeneca. Walsh, Mass Hospital Association.
Laura Pellegrini, Mass Association of Health Plans. Meg Logan, Boston Senior Healthcare. Joyce Murphy, Harvard Pilgrim Healthcare. Lisa McDonough, Philips Healthcare. Mercy Sundell, AGS Health. Chris Hager, Monica Sony, Mass Health.
Julie Pinkham, Mass Nurses Association.
Ron Belmont, Massachusetts Medical Society.
Brian Rossman, Healthcare for All. J.D. Cheslott, Massachusetts Business Roundtable. John Hurst, Retailers Association, Massachusetts.
Jim Hunt, Mass League of Community Health Centers.
Cheryl Pascucci, Bay Street Private Medical Center.
Paul Hanson, Greater Boston Interfaith Organization.
John Irwin with the Conference of Boston Teaching Hospitals.
Scott Hartley with Leahy Health.
Chris Goldman, Partners Healthcare.
Jim Kolovich, Healthcare Alliance, Massachusetts.
I'm David Auerbach, Director of Research at the HPC.
I'm Colleen Elstermeyer, Deputy ED of the agency.
Great. So it's been a couple of months since we were all together, and so I think for the agenda today, it will be a little mix of some discussion and some updates just for you and sharing some information. Just to orient you to, we love to give you lots of paper when you come and visit us at the HPC. So the left-hand side of your folders is save the date, which we'll talk about in a minute for the upcoming cost trends hearings, a meeting agenda, and then behind that is a printed version of our most recent DataPoints brief, which is around the growth in urgent care centers and retail clinics in Massachusetts. We'll talk a little bit more later about some of the findings there. And on the right-hand side is the presentation that I'll walk through with you today. Recognizing that there is a lot going on in the world, I know we had scheduled an hour and a half for this meeting today, but if possible, I think we may try to end just a little bit early and get people to where they need to be today. This is our busy season. I think every season is the busy our busy season at post Labor Day at Health Policy Commission, when we're really in the home stretch for the rest of the year, including, of course, our signature event, the annual cost trends hearing. So do want to spend some time today with this advisory council to talk about the cost trends hearings and particularly hear from you about some of the questions and themes that you would recommend that we focus on this year. We do have some ideas which I'll walk through, but we have not finalized our panels, we have not finalized our topical themes for the cost trends hearings, and purposely wanted to wait actually until after this meeting before doing so. And so really this is one of the meetings, the advisory council meetings I look forward to most out of the year because it really does provide us a tremendous amount of guidance and help in terms of, again, what should we focus on this year, as this is our 6th year conducting the cost trends hearings since the Health Policy Commission took over this responsibility in 2012. So I think with that, I'll jump right into that. So our cost trends hearings are scheduled for October 16th and 17th. Would note and specifically highlight for you that this is a slight date change from what we had publicized earlier in the year. Early in the year, we had scheduled this for Monday, October 15th, and Tuesday, October 16th. As you can see, we shifted this one day. So you are welcome to show up at Suffolk on Monday, but no one else will be there and we'll be setting up. So Tuesday and Wednesday, please mark your calendars accordingly. And if you have not already done so, we do have online registration open for the cost trends hearing, so I encourage you to share that with your organizations as well. And as is typical practice, we do set aside some special spots for members of the advisory council at those cost trends hearings. So please let us know if you plan to attend one day, both days, or some of the days, and we'll be sure to accommodate you accordingly. So for the agenda, I think we are similarly taking an approach that we had last year, which is really about a day and a half. So one kind of full day culminating in some public testimony on day one, and the second day would be finished probably around lunchtime. So we did used to have kind of 2 full days of hearings, and we've pared that down a bit to be a little bit more focused. Very pleased to announce that Dr. Ashish Jha is going to be our keynote speaker on day 1 for the hearings. Dr. Jha is local, but is well known nationally and internationally for his work on a number of different areas. He recently published a pretty seminal piece of literature looking at healthcare costs in the United States versus other developed countries, and what are some of the drivers for some of those differences in costs. So we're excited to work with him on preparing a keynote speech that I think will highlight some of these state versus national versus international issues to help ground our conversation for the 2 days. We do expect members of leadership from both the state legislature, the executive branch, the Attorney General's office, and the Auditor's office to participate as is tradition. And I think similar to how we've run these hearings in the past, we'll have a couple of different panels of witnesses that will engage in a conversation with the board on specific topical areas of interest. I would also like to announce that we do have a secondary speaker who we have scheduled for day 2. Her name is Trish Riley. She is the executive director of the National Academy of State Health Policy, or NASHP. NASHP is a national organization that works with all 50 states, territories, and I think some providences in Canada, and is really a really wonderful organization that brings together health policy people from all of those different areas to talk about some of the big issues happening in healthcare and to be able to have a place for dialogue and sharing of information. One of the areas that we have been most engaged with NASHP over the last couple of years is through their work on pharmacy and pharmacy spending and state health pharmacy policy options. And so we have invited Trish to come and to speak at the hearings really to give both the commission and the public and others a grounding of where other states are in terms of pharmaceutical spending policies. I think there is some conception that this is truly just a federal issue and that there is not a role for states to pursue different types of policies. And what we've seen over the last couple of years, that a number of states have moved forward with some very interesting ideas. For example, drug importation was recently passed up in Vermont. New York has an interesting model of setting basically a benchmark for pharmacy spending in terms of their Medicaid program that could trigger additional negotiations. Some states are thinking about group purchasing in a different way. So there are some options out there, and we hope to have her speak and then have a reactor panel to that to talk about what some of the options Massachusetts might consider, specifically in the pharmaceutical prices, spending, and utilization space. So looking forward to that, and that is had not been, I think, previously announced, so excited to have that. So on this next slide, you can see here on slide 6, some of the potential areas and topics that we've been considering internally in terms of some thematic panels and questions and conversations. I should probably have stated at the outset, this hearing follows on from the annual report that's going to be released from the Center for Health Information Analysis around the state's healthcare performance against the healthcare cost growth benchmark for 2016 to 2017. That report will be released publicly a week from today, and we have a board meeting scheduled here at 50 Milk Street where Executive Director Ray Campbell will present the findings from that annual report for discussion with our board in depth. And so we'll know at that time what the state's performance in the latest year, again 2016 to 2017, of the benchmark. And as we've done in previous cost trends hearings, of course that's a headline number, but underneath that is a lot of interesting variables around different types of insurance, different categories of service. And so I look forward to releasing that report and seeing that report be public, but again, the benchmark is a central theme. We did ask, and some of you in the room, I think we're privileged, maybe isn't the right word, to get pre-file testimony requests from the Health Policy Commission. And through this process, we do get a market scan of some of the ideas and concerns that different market participants have around the state's ability to meet the benchmark. And so one of the clear questions we asked in pre-file testimony this year was around what do organizations perceive as the top concerns or headwinds for the state's ability to continue to meet the benchmark, and what strategies are different organizations pursuing to reduce healthcare spending, and what policy options might the state and the HPC consider in encouraging those strategies to take hold. We do plan again to not just look at healthcare spending, which is of course an important variable, but also how that healthcare spending is translating into premium growth for different size employers and different types of employers, and for different types of residents of the Commonwealth, depending on their community and their location. The third bullet here is something that is following off on some work, and we'll talk a little bit more about this in terms of thinking about the market innovations around timely access to primary care and behavioral health care, and specifically the growth in urgent care centers in Massachusetts, as well as new interesting ideas in the behavioral health care space, walk-in clinics for substance use disorder services, perhaps kind of behavioral health urgent care, as well as new ideas on the horizon, such as mobile integrated health, which recently the Public Health Council just finalized their regulations for, and telemedicine. As I mentioned before, do plan to continue to talk about state policy approaches to pharmaceutical spending, and then some other key areas of focus for our work this year have been around addressing social determinants of health, and a tradition that we've done in terms of looking at past market transactions and what the impacts have been a few years down the line in terms of market consolidations. So that's a lot of different topics and idea for basically a day and a half cost trends hearings, and we may not be able to fully address all of them in kind of a dedicated panel. But I think at this point I just wanted to stop talking and hear from you both any reactions to this list. Does it seem like there's right ideas here? And if there are further suggestions that you think in terms of some of the themes and topics that are top of mind for you that should be explored further in the context of the cost trends hearing. So I would love to hear from this advisory council on that point as well. Brian?
I'm really pleased to hear that you'll be looking closely at pharmaceutical drug prices. I think, as the cost trends reports in the past have shown, it's the largest growing component of healthcare cost growth in the state. And I think I'm really pleased with Trish Riley's company. She's done amazing work for years and years. I've worked for a long time. And I think that will be really helpful for everybody in the state. I'm wondering, in the initial part of the hearing, where you ask market participants to testify about their role, if there's an opportunity to call pharmaceutical drug manufacturers and ask them to talk about it and answer questions from the board about their pricing and sort of why the prices go up for a lot of drugs that are well-established drugs. So that's one question. The other thing I'd like to add also is I'm really pleased you're going to be looking at social determinants of health and seeing what the state can be doing there. I hope there's an opportunity to highlight some of the programs that EPH and others have run. I'm thinking in my head the prevention wellness trust fund programs, for example, and their impact on overall spending levels in the state.
That's great, Brian. And certainly we've been, while we don't have the legal authority to compel pharmaceutical manufacturers or others to participate in the hearings, we have invited them in years past and they have voluntarily participated. I think some of those issues will come up certainly and maybe in the headline benchmark panel, and there may be a role in a spot for a manufacturer there. Certainly, I think in reaction to some of the different policy approaches that other states are pursuing, I think there's another opportunity to engage with representatives of that industry to also hear from them about what their experience has been in some of these other states. Another example that I would give in terms of another state that's been doing kind of an interesting idea was the state of Oklahoma that was approved a waiver to do essentially kind of a value-based contract through their state Medicaid program with a pharmaceutical manufacturer. And that's an idea that we have seen take hold in some commercial space, but this was kind of a new innovation in the Medicaid space. And so that is another place where pharmaceutical manufacturers and pharmacy are kind of working with states on some of these issues.
I testified last year, but to tell the tale. So it's probably we don't shy away from that. And one of the things we suggested in the legislation last year too was thinking about a breadth of folks that can testify. I mean, the hot topic last year, you mentioned it, was how do you hold and check the price of single source generics? It's not really a question that I can answer, but and so we suggested you might want to look at a generic, you might want to look at a classic biopharmaceutical company, you might want to look at a Massachusetts startup. There's different angles to the questions that you might ask, but happy to be, I think on behalf of the industry, happy to be part of that conversation. To the point you just made as well, I do think that having for credible think tank approach to value-based agreements and innovative contracting is where the world is going. That will actually be the solution to a lot of the pharmaceutical. I mean, spending a lot more time talking about implementation, back in dump truck of reports and studies back up. I'm not sure how much more new stuff we're going to learn about policies around things like that. But to get into value-based contracting, innovative contracting, innovative financial agreements that are often hindered by things like best price, there's interesting medium policy topics to get into there.
Yeah, I agree with that, and it's an area where, again, it can be approached in more of a partnership situation with the industry. And I will definitely repeat your endorsement that you live to tell the tale when I invite the next person to come and testify. One other thing just on pharmacy, we did ask the health plans around their relationships specifically with pharmaceutical benefit managers and what their role is in the supply and distribution chain. And an interesting policy topic that I don't know may not come up in the cost trends hearings, but is something that we are examining is around policies where the actual cost of the drug is actually less than what consumers are paying at an out-of-pocket copayment. And in some cases, there have been national stories of prohibitions basically by the pharmacy benefit manager to inform consumers that if they basically paid out-of-pocket with cash, they would actually pay a smaller amount than what their copay is, and that the PBM may retain essentially that additional payment. And so some states, this is another area where some states have been leading in outright prohibiting those gag clause policies and ensuring that, in fact, that consumers are actually informed when the drugs are less than what they would otherwise have to pay in terms of their scheduled copay or deductible. And so another interesting area that we're kind of digging into and examining on behalf of consumers. Just keeping on the pharmacy topic, is there, and then maybe others. Okay, no, Marcy.
This looks like a great list, and it doesn't seem to be any shortage of topics, but I wanted to just add two more to the list. So one is to think about community hospitals. I think if you look at the two pieces of legislation that didn't make it to the finish line, I don't think either had terms for helping those community hospitals that are struggling the most, that kind of work for the rest of us. And I'm wondering if the health policy commission might take a hard look at who needs to be saved and why, and whether there are other ways to do it than what has been proposed to help legislators as they move forward this winter. In that regard, I think that would be a really valuable service. Those proposals that our needs. And then the other one is around value-based contracting. So if we look at in our book of business at Atrius Health, we've seen a huge move across the state the percentage of care that's under each of those POs, which for us represents moving away from interest contracting to something less than, even if it's got some risk involved in it. We look at the GIC and it moved away from full risk contracting for us. And so thinking about, do we really have a commitment to alternative payment methods? What does that mean? What does it mean relative to the kinds of things that CMS is now proposing for ACOs? I think it would be worth revisiting because we keep measuring how we're doing, but we're going backwards.
Yeah, that's two excellent suggestions, and I would just add, on the community hospital point, we created an issued a report a few years ago, community hospitals at a crossroads, that was kind of a full market examination of the community hospitals in Massachusetts and the value that they provide and some of the stresses that they are under. And it has been something that I have thought about in terms of, a few years now later, is that something where we can update some of those analyses and some of that discussion in light of the fact that it's been a couple of years since that report came out and a lot of new data. On the second one, some of these potential themes, I think we are still a little blind about what the CHIA report is going to say, and so where the CHIA report does include trends on alternative payment take-up by different market segments, and will of course have different kind of growth in premiums or categories of service that of course may inform if we see some big changes there that we say, okay, now we really have to talk about this because this is hindering our ability to meet the benchmark. And that may be the kind of the key hook there is around some of the headwinds to the state's evolution on the path. Laura, and then I'll jump over here.
I just wanted to Marcy's point around HMO versus PPO take-up, that is something you're going to investigate. I think it's really important to bring employers to the table, maybe even the GIC, about why they're making their decisions. Because at the end of the day, the employer is the purchaser, and they're doing that for their employees, and the employees are really with their feet and peers. Right? So we can't really dictate from high what people choose. Like product design, I'm happy to see that there'll be an evaluation of past market transactions. I think that's really important to Matt around integrated systems, exactly how we're delivering on the promise. And we think that should be a major part of every annual cost trend steering, so that we can hold the system accountable. So we're including that.
Great, Paul and John.
So my comment actually builds off of Laura's in terms of evaluating the impact of past market transactions. But I think you want to add to the list, including how government does its continuing oversight role. And the reason I say it, I'll just take a minute to inform you, but I got a letter forwarded to me that DPH wrote to lawyers that were involved in the 10 taxpayer group tied to the Children's Hospital transaction. Where effectively the letter says to those lawyers who had made an inquiry about whether the hospital was going to, or DPH was going to follow up with the hospital about reporting on the condition information requests that are essentially 6 months after the transaction, the hospital needed to report about patient origin data. And so far as the hospital's chosen not to do so, when you read the letter, the DPH is effectively abandoning its need to collect that information now. It just says, well, we'll collect it later when the hospital's open, and by then we might be experiencing, from my perspective, some of the spending increases that HPC projected, or the impact on the pediatric hospital market of other providers being threatened. And so it seems to me that if we're going to evaluate past transactions and we write conditions for them, or DPH does, and then they don't follow them but seem to be abandoning them, that has an impact on the whole market review process. So I don't want to take more time now. I'm happy to pass out just for my colleagues on the table some copies of that letter. But I think that's a relevant part of the follow-up to these market reviews that you do and what happens to them. So I'll pass a few copies out and I'll stop.
So yeah, I'm glad to see that telemedicine is here on the list. And we had a panel probably 2, maybe 3 years ago on telemedicine, and I wonder if you'd consider kind of bringing back, not necessarily those people, but the programs that were highlighted, because a lot of them were in the early phases. They were either targeted towards a specific condition or geography, and a lot of people explained that there were some pretty substantial obstacles. So maybe kind of revisiting that to see if those obstacles still exist. I think at the federal level, some of them have been alleviated. I mean, we would argue that there are still some pretty significant ones at the state level, but kind of revisiting what was maybe not promised, but what was teed up as kind of a growing trend in telemedicine, and especially I think those panels highlighted the role of telemedicine in behavioral health conditions.
John, if you, and this I think goes just for John, for everyone on the advisory council in terms of some of these topics, if you know of organizations that are truly kind of doing interesting, innovative work or have unique perspectives that will, elicit the type of discussion and conversation that we seek to have with the cost trend hearings, please let us know. I think where I have been thinking with this specific panel and kind of thinking about new ways to get timely care to patients, the care that they need, I was thinking about kind of a telebehavioral health component here. So again, if people have ideas and suggestions, we did a telemedicine grant program. Those grants are in the process of expiring, but we learned a lot through that program as well, and those were focused on telebehavioral health. And some of the programs I think we were really encouraged to see are going to be able to be sustained and expanded into the future even after the grant funding, where they've been able to get some payer participation in those models. So again, open solicitation for great speakers and organizations. John?
Thank you, David. I'm glad to see the second bullet under digital themes.
I think one of the things that we've got to delve into much more is why are small businesses and employees of small businesses continuing to see premiums go up above the benchmark each and every year, yet they're in the same risk pool as the connector, and they have among the lowest rates in the entire country. And we're the only state in the nation which has a merged marketplace where we're putting on a group together with a small group. And it isn't just that the premiums are going up, it's the quality of their coverage is dropping each year as well. Whether lab tests are no longer $8 one, they apply to your $2,000, $4,000 deductible. Maybe it's because we are the only state in the merged market, with the merged market, and therefore an employer of 45 employees are forced to buy essentially 45 individual policies. Whatever the reason is, we really have to start looking at the problem of what's our small businesses and their employees and what's happening in their coverage and premiums. So thank you for adding that.
Yeah, thanks, John. And actually, I would say that idea was, I think, sparked a previous advisory council meeting, I think at the beginning of the calendar year, when we were going through some findings from last year's cost trends report. And there was a conversation around the fact that, total healthcare spending under benchmark I think was 2.8% in that period of time. But the actual experience that many employers were feeling in terms of the premiums was much greater than that. And what is the connection between the spending targets, which of course are retrospective and looking at things, versus premium setting, just prospective. But I think there's some interesting dynamics there, and certainly, I think there is some disconnect in some of these conversations. If we look at the benchmark and it is very, healthcare spending is moderated, and that's a great thing. But in terms of what actual people and employers and consumers are feeling, feels maybe discordant with some of that, and I think worth exploring and having a discussion about. Ron?
Two things. So one thing is that looking at the increasing deductibles that patients have to pay, I think you really have to look at the population demographics. As you go down in income, the tendency not to come from appointments to avoid paying the deductible goes up, so that lower income people are avoiding care at a much higher rate than those with higher income. The other thing is, looking at community hospitals, you really have to look at the population. So when the income is high, there's a tendency to jump over to the community hospital and go to the big hospitals in towns. I think that when you do your analysis, you really have to look at what the population looks like. And you're looking at market opinion. I just went to a meeting there, community health services, and they have some remarkable services, but they have a sub-select group of the lower third of the income. So they have a tremendous burden there that is not borne by other hospitals. So I think that looking at whom you're managing. When I look at the South Shore, we do a smoke out program in the schools. If you ask me to do smoking and Hingham and Cohasset or pulmonary disease, I'll do it because nobody smokes. But if I go to Randolph or Hull, everybody smokes. And so, when there's a tremendous amount of data being gathered about us, and that insurance companies are going to have a lot to know about what you do, how likely you are to behave in a certain way. And so I'm worried that down the road we're really going to see redlining and avoidance of populations as we start to say, let's insure it.
It's a great point, and I think certainly on the high deductible piece and kind of the affordability and the differential affordability for different communities in Massachusetts is something that it's not just one average number for the state, and people are feeling these things in different ways, and I think it's always a good opportunity to dive a little bit deeper in terms of what does affordability really look like in different areas of the Commonwealth.
The other thing is, have you looked at, there's a movement about the direct primary care, where patients are asked us to pay a certain amount of money. And groups on the South Shore have actually approached the Department of Electricity about a small monthly payment by the patient, but access to physicians to keep them out of the expensive emergency room. So there's actually a net benefit savings for both, but there are insurance problems with referrals and so forth, with payments and that. But I think that's a model that perhaps has to be looked at.
Yeah, that we did invite Iora Health last year's hearings, and they had this kind of direct physician model, and certainly have a lot of promising results from that, and something that we're continuing to track. Steve?
Thanks, David. I know at the last advisory board meeting we talked about the ballot question. There some disagreement about whether the issue is right yet. And certainly now, as we all know, the question is on the ballot, it is right. Having talked to providers, and there are some in the room that can certainly comment for themselves, I've heard that that is the single greatest issue for their ability to meet the benchmark this year, next year, and any year moving forward. Also, the single greatest threat to community hospitals that are comparable. It would be irresponsible for us not to take a major portion of this cost transferring to take a look at question one. And following up on Laura's point, I think the beauty of it is that we do have past market transaction in the ICUs to take a look at. And there was a report released yesterday that showed that quality has remained stagnant, but cost has increased. So I would suggest that you have a panel and have both sides chat about it a little bit and what it might mean to come.
I think there's no doubt that this is incredibly important context at the time of this cost trends hearings, and whether you're a proponent or opponent to the ballot question, I think everyone can agree that it is a significant decision that will impact the healthcare system moving forward. So I think open to final consideration whether we carve that out into its own panel and conversation, but I certainly cannot imagine that that will not come up during the course of the hearings.
If you do decide to work on that, you might think about inviting someone from other parts of the industry, whether that's HML or ambulatory space, hospital issue, we'll give you my response.
Come on.
Sure. Obviously, I think that it's an important issue for everybody to want to take up, and I think that's a conversation that we can have what a panel might look like. I mean, frankly, I think there's a lot of issues that should be taken up this regarding the past experience in terms of mergers, the implications, the current mergers that are taking place, the regional growth that's happening, moving from some costs, and there's a plethora of behavioral health changes, there's a lot of issues out there. But I know this topic is near and dear to everybody's heart right now, so I don't think I'm going to shy away from it. If you want to take this up, that's fine. But we would expect to have full involvement in terms of what this would look like. To be perfectly candid, I would not want this to be utilized as a bully pulpit for one side's view of the issue. If you want to have a deep dive into it, then let's do just that and have some real clean data and some honest analysis of it. And is right on that. Certainly, the most recent study that was brought up, I have my own particular viewpoint of that study. So I'll leave it at that. If we're going to do that time, though, honestly, it needs to be done with the full consideration of all stakeholders, not necessarily in this room.
And I would say time is pressing, obviously, on all of this. I mean, we are recognizing that we're 5 to 6 weeks out, and still have not invited panelists. So we are understanding that many people need to know and to plan accordingly. And so thank you, Julie. Appreciate that.
I guess I should make it clear, I would have full expectation that the California Nurses Association will be allowed to participate in this, given the fact that this has been in effect out there for a decade now. And I don't think that we have to wonder what the experiment will look like. We actually have some really good data and experience to go from the largest economy out there. So I want to make that very clear. I would want to make sure that individuals from California can participate.
All right, well, we can take that offline. Any other ideas for and topics and themes for the cost trend series? This was really helpful, and I think in some cases validating to some of the ideas that we had previously had on this list. Okay. All right. Well, seeing none, thank you. So for the next part of the agenda, wanted to share some work with you that we recently released to get some of your feedback on where to kind of take this examination next. And so this has been something that actually also came out of a previous advisory council meeting in terms of thinking about the growth of urgent care centers in particular in Massachusetts. And so this was something that the research team spent many months working on. Interestingly, I think through this research, we found that there is not one place to go and get this information about where these urgent care centers are located, who they're affiliated with, and required, in many cases, when they were established, required us, in many cases, to physically pick up a telephone and call the urgent care center and ask some basic information about when they were open, can they take any patient, what types of services do you provide, when were you opened, and had to sometimes have multiple phone calls with one urgent care center just to track down some of this basic information. So I would say at the outset, we understand that this is kind of a snapshot in time examination of what the market looks like right now, and this is evolving very quickly. I think even in the time, and this data points I think we released about 5 weeks ago, there have been new developments in this space. I would note South Shore Health recently acquired a series of urgent care centers on the South Shore that was a for-profit company and is now being brought in under the health system, and understand that other organizations such as Partners, but others as well, are continuing to expand and build these urgent care centers. So here on slide 9, you can see kind of the key findings. Certainly a tremendous growth in both minute clinics and urgent care centers from the beginning of the decade. Minute clinics, as you'll see, are kind of resale clinics, have kind of stalled out in terms of their growth. We did do an examination on the cost of these centers versus the emergency departments, and also looked at the types of services that were being provided. So just to give maybe just a 5 to 10 minute kind of overview of these findings, and again, these are on our, we have a written copy, but there's also online, we have an interactive Tableau version where you can go in and look at different things. So I'm going to turn it over to our Director of Research, David Auerbach, to just talk about this. And again, I think what I most want to hear from you is what questions do you still have that are unanswered, and where can we take this examination next, because this is a really important market trend.
Okay, thanks, Dave. And so this is the 8th edition of our DataPoints series, and like all of them, they're web-enabled with Tableau graphics, and they're relatively brief and descriptive, and usually they're the beginning of an examination of an issue, but we might then take a deeper dive and further analysis. So I'm going to kind of just go through what you'll see on the website if you go there, and Shwaya, who did a lot of the underlying research, is going to help me as we scroll. Okay. So first, what she's showing here, I think you can all see that on the screen, is as David mentioned, the top line trend, where we tracked the number of centers of both types, urgent care centers and retail clinics, over time, here from 2010 to 2017. And you can see growth, but dramatically different trends. The urgent care centers, the number in the state is over 150 now, and it's just been accelerating growth since 2010. And that probably is continuing into 2018 from what we've uncovered already. And the number of retail clinics, as you see, has somewhat flattened out over the last couple of years. Okay, let's continue now. We cut this data in a number of different ways. We identified which of the urgent care centers were under hospital's ownership and which were independent physician-led or parts of other physician-led chains. And you can see the majority of that light blue on the bottom are physician-led, but that number of hospital-led, such as the Partners Urgent Care, those have been growing recently as a percentage of the total. So that's and there's a small number of community health centers that are also included at the top there that function like an urgent care center. They're open all the time. They take walk-ins and they treat a fairly wide range of problems. Okay. The next graphic is showing not the cumulative totals, but the number of new entrants in any given year. And there you can see again, as I mentioned, in 2017, the big growth in the number of hospital-led centers there, about 15 came online just in 2017 alone, compared to I think a slightly smaller number of physician-led urgent care centers opened in that year. Okay. Next, we looked at of the urgent care centers that were hospital-owned, who were the major players, which were the hospitals. And then the biggest one there is Partners, with I think about 16, and you can see a number of the other groups have maybe 5 each. I don't know the names there, but you compare what the landscape looked like geographically in 2010 to 2018, you really see this dramatic difference. The top graphic is showing the locations of retail clinics and urgent care centers in 2010. And then on the bottom, we have it speaks for itself. Large cluster in the Springfield area and the Worcester area, all around Boston. A number of urgent care centers on Cape Cod as well. You can see if you scroll down just a little bit more. Okay. So then this is also interesting. We have in mind emergency departments through a lot of this as another place where people can get some of the same needs met. And there was an interesting paper in JAMA Internal Medicine a couple days ago showing that for a specific set of low acuity conditions, the number treated at urgent care centers and retail clinics has now outpaced the number treated at emergency departments, which is something we see as well. That's probably a positive trend. So it's important to then contrast as we go to the next one. For a given geographic area, do they have more EDs or do they have more urgent care centers or retail clinics? What options do folks have for these low acuity conditions? And there are some interesting patterns there as well. They're kind of inverse, where the top is showing that's the ED density per population. We see a higher concentration of those EDs in the western part of the state, on the North Shore, on Cape Cod, and then the urgent care centers and their retail clinics are distributed a bit differently. More of them in the areas around Metro Boston. So you get some interesting difference in the ratios of what sites people have available to them. And something we have in mind is the next look is to see how does this influence where people actually go? How does this influence cost of care and convenience of care? It should have. Okay. So then we dug a little deeper into the geography of, we often hear, are these sites locating in high income areas? Are they located distributed evenly across the state? At least in one look, we did arrange all the zip codes in the state by income in terms of quintiles. Top 20%, bottom 20%. So those 5 quintiles, and if the centers were locating perfectly evenly across those quintiles, you would see flat bars at 20% each. And so what actually happens is the urgent care centers are on the right. They're skewed a little bit towards the high income areas, as you see. More of them are in those high income zip codes, but it's not skewed all that much. The retail clinics on the left are skewed a bit more towards the high income zip codes of the state. That's what that looks like. We looked at costs and conditions treated at these sites. You can see in the blue, we're showing the top 10 conditions treated at retail clinics. 20% are pharyngitis and sinusitis, low acuity conditions like that. The bread and butter of retail clinics. The urgent care centers are treating a wider range of conditions, so there's no one thing that's going to account for 20% of visits, but also heavily concentrated in some of those sorts of infections and other issues like that. Okay, we compare costs, I think, are next, and this is not surprising. The cost of treating these conditions in an ED versus these alternative sites is dramatically different. And we're showing the total cost in the yellow and the copay that a patient would pay in the blue. And this is data from 2015. So we do have that richness that asks different questions. We'll continue to get this along with other data in the All-Care Claims database. We'll get 2016 soon, and we will be able to track patients and track visits and costs of those visits. There's more if you want to look at the website.
So one of the, just to tee up the conversation, so we did ask some additional questions of both urgent care providers, for profit, either locally headquartered or nationally headquartered, as well as some of the health systems that have been building and establishing these urgent care centers in our pre-file testimony. So we will have not a comprehensive scan, but we will have some more data points to look at. And some of the things that we asked about in those pre-file testimony is really around the patients that are being served by these different sites. Are they predominantly commercially paid patients? That maybe our hypothesis. And what is the percentage of Medicaid or Medicare patients that these urgent care centers are serving? As well as what is the integration that they have done back with primary care or back with the healthcare system, so that that these are not creating another silo in our healthcare delivery system, and ask questions around their ability to share clinical patient records in real time back with their identified primary care provider or with their health system. How are they doing that? And is that something that's being faxed over days after the visit, or is it something that is truly integrated? So to try to get another level of information around their incorporation into the broader healthcare system. So that will be something new that we don't have that data yet, but will be something that we'll have for the cost trends hearings and to tee up some of those conversations. So with that being said, open to any other reactions and questions. I'm going to go around this way, Paul.
So first, on a personal level, the greatest value of the urgent care centers to me is that if I go 2 miles past where I live south on Center Street, which is about halfway for my run, I hit one partner's urgent care center and turn around, or I go the other direction, go 2 miles north and hit the first one's on the Needham line, the other one is closer to Watertown. So it's very useful for me as to help guide my 4-mile runs. But my question is actually for Lois, which is that I remember when I was a commissioner, we looked at some of the legal structures for the opening urgent care centers and noticed that the reporting laws weren't triggered, even though they involved affiliations or partnerships, because in one case, we had a healthcare provider in the state doing an affiliated agreement with a management services organization, and therefore it didn't trigger reporting under the notice law. Is that still the common structure for most of these, or meaning where there's a partnership, or do we not even know how the legal structure of most of these urgent care centers?
I just say that the structures tend to vary. They may be hospital licensed, they may be separately licensed as clinics. I think there's a wide range of structures of corporate data.
So the HPC would get no information then from that traditional notice structure. They would only do it via a report like this, right? For the most part, for most of these urgent care.
Some of these would require a material change notice. In the case of a joint venture, or in the case of the recently, the South Shore example, that was a material change notice that was filed with us and made transparent through that process. But some of these may be just capital expenditures of the health system or of the for-profit system, which may not require an MCN.
Or it could be, because I think, like for several of the partners, I believe it's a joint venture with Fresnia's Healthcare, which I always thought was a healthcare organization, but apparently in our state it's only a management services organization, and therefore the relationship between the two doesn't trigger notice under our law, so under your regulations.
Jim?
Thanks. Funny I would comment on this. I'm very happy you're going to do a deeper dive, because we're really interested. We've been studying this for years and have continued to propose that with venture capital, community health centers could be doing this in the shadow of where urgent care centers being opened up either on non-profit or for-profit basis, and we could be doing more of this. I'd be really interested in getting at the who using urgent care centers in certain places in the state, particularly Western Mass and the Cape. I visit the one at 134 exit 9 on Route 6 regularly just to check the license plates in the parking lot. We have to send the commission a picture of the license plates, but it's very important for folks from New York and Connecticut and Rhode Island to be able to get urgent care, and there's a heavy use, and from all intents and purposes it's very well utilized, and it is a consumer convenience, so I get all that. All the way back to CVS and their work in Rhode Island, standing up interoperable urgent care through the Minute Clinic model. We thought that there need to be interoperable medical records with, if you will, primary care medical homes, and most importantly in the state of Rhode Island, referrals to those primary care medical homes when people did not have a source of care, rather than them just be treated and treated for urgent conditions while overlooking what might be the mind and body experience of people in the holistic approach. So I think there's a lot of work to be done there. There's obviously a need for capitalization, which the nonprofit side generally doesn't have. But we get the consumer convenience, and I'm happy to participate in sending you some of the names from around that were integral in that work with CVS in the first iterations.
That's great, thank you. Ron?
I don't know if you've seen the JAMA article on the utilization of antibiotics in urgent care centers and walking clinics and so forth. So it seems like it's relatively high. I think back in 2014, I think you met with Chris Dodd in the White House discussing all this and so on. And, you know, it was a grand experiment to try to improve access, but the groups including, I think that there are issues with quality and training and so forth involved. So I think that it would be very interesting to see what your studies show in this regard. The other thing is that, in practice, for a number of years, I never got a single note from CVS. Never. The patient would come and say, "Oh, they said I had atrial fibrillation. Do you have an EKG? Do you have a note?" No, I don't have anything. So I'm at square one trying to figure out what the actual problem is. The fact that these centers are being purchased by hospitals gives an opportunity for integration that I think could improve that. I know CVS in some states has been affiliated with we have a kind of scattergram in this thing, so I think that's something that we can look at.
Thanks, Ron. I would just say I read the headline of that article you mentioned, and I do think that we will be able to have some analysis on prescribing patterns and for some of the antibiotics that you mentioned, which would be really interesting. The other thing that you just reminded me was we also asked through pre-file testimony how often are patients arriving at the urgent care center and kind of immediately being referred to a more intensive setting. And so we're interested to see what we hear back in terms of that. I think it was a little bit different what you were just mentioning, but there are cases where that is not the right setting for them, and they may be going directly to an emergency department. We're interested in how often that happens, and in that case, is there potential double billing that is occurring?
We have gotten urgent calls, have a patient with chest pain, I sent to your office and said, I have an EKG machine, but I don't have a laboratory and other things. So, this patient is that sick, we have to send this patient here. So, it really hasn't avoided saving, it's avoided the savings that we hope. Now you have 2 billion, you have ER, and you have the urgent care. So that liability and responsibility, if you try to advise somebody over the phone of a patient you've never seen, it's huge.
Was there, and you looked at the geography and whatnot, was there any difference between the urgent centers that were homegrown, I'll call it for lack of a better word, versus external national firms, or did they follow the same breakdown in terms of geographic and economic placement?
One thing is I can send you the spreadsheet and you can see the ownership and the zip codes. We only looked at that kind of just casually, but you certainly notice that the different chains tend to be clustered in a geographic area. So there are patterns. The AFCs, a lot of them are in certain parts of the state and the parallels. So you will see those patterns.
And similar to that, the for-profit experimentation, do they have any contract relationship with any of the systems?
I'm not really aware of that. So.
That is a question we asked in the pre-file testimony, so we'll get to what is your affiliation or relationship status with other hospitals and health systems or the non-hospital-based systems.
One of the things that you look at when you do market reviews is market share and competition. And I want to be careful that we're not siloing ourselves when we think about urgent care. So we look at the top 20 diagnoses. I did a study a couple years back, and basically looking at this list, it comprised something like 40% of our internal medicine business. So this is internal medicine. This
It's a great suggestion, Marcy, and I would jump in a little bit ahead. Note that on request of some of our commissioners, we are doing that type of kind of market examination for imaging services and lab tests, where we have seen Shields and Quest and other organizations continue to grow in that space. And so, again, just to try to understand how is this market evolving, and I think urgent care, kind of primary care would be next on that list in terms of seeing how some of these new market changes are affecting where the services are being provided. So it's a good suggestion. All right, seeing no other comments on this one, thank you, that was very helpful, and continue to work on that particular topic. Jumping to slide 11, I would put this kind of in the category of wanting to let you know some of the things that we're working on. So we are also planning for our annual cost trend report. This is obviously still in development. And we are still working on the specific topical areas that we hope to examine, but just to kind of give you some sense of this, and any feedback you may have is very welcome. In addition to kind of standard trends in spending and care delivery and payment reform, which we cover on pretty much an annual basis at this point, we are excited that this year, for the first time, the hospital discharge data will allow us to understand patients who arrive in the emergency department and then are admitted into that hospital. This was actually a data gap that had existed in our database for a long time, where those patients who were admitted to the hospital were kind of in the admission part of the data set, and we couldn't link that to the emergency department part of the data set. And so we want to look at this data and understand what we can see in terms of some different trends. Do we see differences in the rates at which hospitals, are admitting patients for what types of services and conditions and diagnoses? And so this is kind of a new data set that we're excited to kind of dive into. David, I don't know if you want to say anything more about this data. Did I do that justice?
We did that one. So we started initially working on this, and we do see very large variation by hospital. We're making sure that we control for the types of patients that are seen, so we're not mixing in differences in patient acuity, but it's fascinating data.
You may want to take a look at patient age, since
Sure.
a lot of times all the patients are sort of automatically.
Yeah.
Just curious too, are you separating out inpatient admissions from emergency admissions?
Where you're tracking the from the emergency department to the inpatient, and also including observation stays.
Yeah. So it's almost two. Thank you.
One thing, looking at analysis of our emergency, we find that the growth of the urgent care centers, the acuity of the visits to the ER is up. So even though there's still a very high volume of the ER, but the acuity is much higher. So the ability to handle that load is somewhat, the care in our hospital is good, but patients need going to the emergency room, they're going to wait for so long because the volume and the number of ambulances coming in. So that's something that we basically look at. I think the easy cases are sort of set off to the side, and therefore, different kind of loads on the hospital staff.
So the next one down on here is looking at some differentials in terms of public and private payers and the prices that they're paying for certain services. And I think one of the questions we're examining here is one that Chair Stuart Altman has been focused on for a lot of his career, is potential cost shifting from public payers onto commercial payers. And I think especially looking at Medicare over the last couple of years, where there have been a very low kind of Medicare growth in terms of total spending, do we see that some of that is shifting onto the commercial side? And so we'll be looking at a set of services and understanding what the average differentials are for depending on different types of payers. Next one on this list is an update of an analysis that we did a year ago, where we were able to attribute patients to specific provider organizations and then look at their performance on total spending, on emergency department utilization, inpatient versus outpatient spending, and did find some really interesting variation among different provider organizations and the care for those patients. And so what we're evolving this to this year is actually looking at very specific patient cohorts and their experience in different provider systems. So we're looking at patients who have diabetes and trying to understand how does the care that they receive from provider system A look different than from provider system B. And we have a couple of other different kind of patient cohorts to try to get a more homogeneous group of patients and then to be able to really see, are there a lot more tests that are being run, is there a lot more imaging, is there a lot more prescriptions that are being done in some organizations than others. And again, where we see variation, we see an opportunity perhaps for optimization. On the right-hand side of the topics bucket here are some things that we are looking at probably in separate reports and briefs. So this first one is, if you don't know what brown bagging and white bagging is, I'm not going to try to explain it right now. But if you do know, it is around kind of different ways of specialty drug distribution. And we were charged by the legislature with examining this practice and making potential recommendations to the legislature. The second one, we also have a report coming out this fall around access to dual diagnosis services or services that can treat both substance use disorder and mental health conditions essentially at the same location. Again, trying to understand where these locations are in the Commonwealth, what are the wait times and barriers to receiving care there. And so I think we'll have a fulsome report on kind of the state of dual diagnosis services in the Commonwealth. I mentioned the examination of kind of contracted ancillary services, and I did mention the prescription drug charges as well. So those are some things that are kind of upcoming from the Health Policy Commission, even just in the next couple of months. So a lot on the table, and a lot to continue some of the great work that we've done before. So I don't know if people have any thoughts or reactions to that. Seeing none. Just a couple of other kind of quick updates on things that are upcoming. Jumping right to slide 17 in your packets here. We are also preparing a series of policy briefs about certified accountable care organizations in Massachusetts. We did, through our certification program, we are able to receive, we received a lot of information about the 17 ACOs, and so are preparing a series of public reports that document different and examine different parts of how the different ACOs are organized, how they are, what some of their different capabilities are, and really, again, to just provide a landscape of how the ACOs are functioning in this market. And this really will be a baseline for future cycles of certification. So this upcoming policy brief is around how ACOs manage their population health. And so we asked questions very specifically about how they perform risk stratification for their patients, how they assess patient needs, and then how they design programs to address those unmet needs. And we require them to have at least one program that address behavioral health needs and one program that address social determinants of health. And so while some of this data is confidential, and so we're not able to kind of identify individual ACOs, we can still nonetheless get a pretty good landscape of where these ACOs are in terms of some of these questions. And so some key findings that will be in this brief is that ACOs tend to use payer reports and claims data as their main data sources for patient stratification. A number of the ACOs, I think very encouragingly, were continuing their chart investment programs as their models for population health and addressing social determinants of health, and are really working on integrating behavioral health into ACOs. This next slide I think is really interesting. This is slide 19. So we asked every ACO, how are you assessing your patient population? What types of fields do you fill in when a patient arrives for a visit in terms of understanding what their needs are? And so there's 17 ACOs, and basically what you can see here is that pretty much everyone is asking around things like language, race, and ethnicity. But as you go further down this list, you can see that a minority, and in some cases only a small number of ACOs are asking about things related to food insecurity or access to transportation, sexual orientation. Again, I think there's probably some space for improvement in terms of how ACOs are really thinking about the whole person needs of their populations. And you can see that there is some variety based on what they're asking about their patients. So this is the type of information that we're able to kind of pull from this certification program. Again, kind of in a de-identified way, but begins to help us think about where do we want to push the certification program in the next round, because we are planning to update the certification program for next year. Brian?
Real quick comment, the Mass Health ACOs are now required to do a patient needs survey on health-related social needs among them. And so that, I think these numbers will change once the Mass Health program is full.
Yeah, and we do expect that, Brian. That's a really good point, that in some cases, this certification information is free Mass Health and will be a baseline where the next time that we do this, we'll actually, hopefully, I think, see a lot of these things change. And we do know that ACOs are working very hard on some of these programs. Clark?
Yeah, I was going to say, it's a similar thing. I think what's been helpful, at least for the Mass Health in the Boston area ACOs, is that we have been able to come together and do a lot of sharing, so it's really collaborative investment improvements, a lot of collaborative. I don't know what the role is at HPC and sort of how to bring some of these learnings forward, but as I look at some of these things around literacy, sexual orientation, food insecurity, there's a sort of a data, around doing it complicated. So anything we can do to kind of spread those learnings, I think, would be useful in HPC as well.
That's great, thank you. And I think we are aware of that consortium and very encouraged by that. So
we had a session on this in, I think, 2016 at the Commission on Healthcare Disparities, and the people from Wayne State presented. It turns out that their clinics are in vastly different areas, so they were actually able to tailor their screening to the demographics of their communities, and that enabled them to have much better success. So from an urban to suburban population, they were able to screen for things that were most important there. And I think that's the kind of thing that we have to do with it.
And this is, to be clear, to Ron's point, asked at the ACO level. And we are asking these questions about not just their Medicaid population, but how are they assessing the needs of all patients that arrive, so commercial patients as well. And so I think some level of customization may be certainly appropriate. So, so look forward to that. The other thing just on ACOs that I'll mention is we have also created one-page profiles, which will be released soon, of each of the ACOs that include some just basic information. Where are they located? What areas do they serve? What risk contracts are they operating under with what payers? How many physicians they have in their organization. So again, we're trying to mine as much information as we can to be able to put some of this into the public sphere and then update it over time as the ACO experiment continues.
David, what's your plan to circulate these? You can put them on your website, or how are you going to disseminate them?
So we tend to do a combination of a couple of different things. And we do have kind of mailing list listservs where we push materials out. They all live on our website. We do Twitter and targeted outreach to some organizations. And the ACOs that we are profiling have been consulted about their profile. And so we want to actually get that back to them because they may find that very useful as well.
I was going to add people like Marcy and Atris are really helpful in getting information out there. Blogs, people who are sort of interested in this type of work that we're doing. But did you have something in particular that you wanted to suggest?
No, just if you needed help turning them around.
I would love
So I think the last thing in this entire presentation that I just wanted to mention to you is an exciting new relationship that we have recently announced with Pulse at Mass Challenge, which I've been told this morning has now been renamed to Mass Challenge Health Tech. But for those of you who aren't aware, Mass Challenge is kind of the state's public-private organization that's focused on encouraging innovation and Pulse particularly in the digital health space. And they provide funding and support to startups. But one of the programs that they've been recently launching, and they launched last year for the first time with the Executive Office of Elder Affairs, is to partner with a state agency and actually put out some challenge areas to the digital health kind of startup innovation community, and connecting those companies and organizations with the state agency or with providers and others to test new ideas and to really kind of cultivate this ecosystem that Massachusetts is blessed to have. So we are a champion in this upcoming year, and we'll be working with Pulse on some challenge areas where we hope to be able to work with some startups and connect them actually to the organizations that we work with through our investment program. So it won't be necessarily working with us, but we will be a funnel and a channel to work with the community health centers, the community hospitals, and other provider organizations that we work with through our grant programs. And I think one of the things that excited us about this opportunity was we do know that some of the very biggest health systems have their own innovation offices where they have good insight into what areas they may want to work with. Not all provider organizations have that capability and those capacity and the resources to be able to connect with emerging ideas. And so we see this as an opportunity to be able to really help some providers who otherwise would not have the capability to evaluate who would be a good organization to partner with and to work with on specific challenge areas. And so slide 25, these are the 5 challenge areas that we will be seeking proposals from and hopefully connecting with other organizations we work with. And they are, as you can see, some of our bread and butter challenge areas: reducing avoidable ED visits, readmissions, addressing social determinants of health, and improving timely access to behavioral health care. So an exciting opportunity and kind of a test, and we're excited to work with Pulse on this particular thing. So wanted to mention it here at the Advisory Council, if you or your organizations are connected in any way to companies or startups or other organizations that may be interested in applying, want to connect with us, and we'll be able to share all the information with you. So with that, there's more information in the packets about where we are with some of our investment programs. I won't run through that, and you can review at your leisure. But I want to open it up to any last comments or suggestions or feedback. Ron?
I just had a question about CMS's push to really make forays and take downside risk. A friend of mine runs a successful 350 ACO in Atlanta. They've done 3 years, successfully done shared savings, but they were told by CMS to go to the downside to the effective model. So they actually partnered with 3 other successful ACOs and went back to CMS and they came back off. There's a lot of trepidation in the community about doing this, cost of stop loss, insurance, and so forth, and complexity. So I think that they could be shooting themselves in the foot if they push people who've actually done well so far to do something in that way.
Right, we heard a Miller's piece out last week, which criticizes the push into having to take downside risk, and I'll share with you that you'll get better results.
Ryan, just want to?
Yeah, I just want to make a quick point about the terminology we're using, about health-related social needs and social determinants of health. They're not quite exactly the same thing. I think we need to be careful when we ask health organizations to participate in either of those things. So if a patient comes with housing needs and the health system provides the patient directions on how to go to the housing office and how to sign up for housing vouchers, that's addressing the patient's health-related social needs. And it's a great thing to do to help that patient. But if a health system invests in low-income housing in their neighborhood, that's dealing with the social determinants of health for the community. And I think we need to be careful about keeping them separate. I think a lot of what we're asking ACOs to do, for example, is not take care of social determinants of health, but rather deal with the patient's health-related social needs. And both are important, both are good, but we need to sort of keep them separate, I think, when we talk.
Thank you, Brian, and I was not perhaps being precise on this, but in this context, we are talking around health-related social needs, and in some of our grant programs, it's been more on the health-related social needs. In other policy conversations, talking about the broader social determinants of health, including education and the environment and other things, I think is also a really important conversation. So, but thank you. All right, well with that, I think we'll end a little bit early. Thank you all for the great feedback and suggestions today. This was a good conversation, and look forward to seeing you at the cross-trends hearings. If you want to come next week to the board meeting as well for CHIA's release of their annual report, I encourage you to do so. We'll have a board meeting just for that purpose. So, thank you.